Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, some of you are probably wondering, what the heck is this image? And some of you already know what this image is based off of the glomeruli that is present. Some of you have even took it a bit further and recognized the onion skinning and know what pathology is occurring. We're going to be talking about that and much more in this lecture on arteriosclerosis, aortic dissection, and aneurysm pathology. This is covered in your book, Medical School Pathology and Step 1 Review. If you don't have it, you can scan this QR code here and find it. But I know you have it already because you're not a procrastinator. You're taking the reins on your education, making sure you have everything that you need to succeed. And I'm proud of you for that. Let's talk about arteriosclerosis. Okay? Now, what is arteriosclerosis? Basically, it's hard arteries, right? Arteriosclerosis is due to the blood artery wall thickening, literally hard arteries. And we can see this histologic section again, showing that onion skinning of a renal arteriole. The types of arteriosclerosis include atherosclerosis, arteriolosclerosis, and Monckeberg Medial Calcific Sclerosis. And those deal with the large arteries, small arteries, and hardening and narrowing of small to medium-sized vessels, such as the arteries, respectively. Now here we have an example of arteriolosclerosis. Can you see in this image the breast mammograms showing several calcified arterioles? Here's another example of a micrograph showing hyaline arteriolosclerosis in the kidney. See all of that thickened eosinophilic tissue? Arteriolosclerosis can even affect the vessels of the brain, as we see here. You can pause it and read through the description if you want, but for brevity's sake, just know that arteriosclerosis primarily affects those smaller vessels. And here's another example. Can you recognize where this organ is from? Kidney? Right. This is an example of nodular glomerulosclerosis, as well as hyaline arteriolosclerosis. And you can see all of this eosinophilic thickening, indicating that that pathology is occurring. Now let's talk a bit about atherosclerosis. Atherosclerosis causes blood flow to be obstructed by intimal plaques, as we can see here with this gross pathology of an aorta with significant atherosclerosis. Now, atherosclerosis typically involves medium-sized and large arteries, those big arteries, hence the aorta, right? Atherosclerosis frequently develops dystrophic calcification. Arteries commonly affected by atherosclerosis include the abdominal aorta, the internal carotid artery, and the popliteal artery. There are two categories of risk factors for atherosclerosis: modifiable and non-modifiable. Now, modifiable risk factors, guess what? Can be modified, right? So modifiable risk factors of atherosclerosis include hypertension, right? We can get that blood pressure down. Hypercholesterolemia, right? We can work on that. Smoking. I know it might be difficult, but you got to put the cigs down. And diabetes. We can work on your blood glucose levels. Modifiable risk factors. Then there are non-modifiable risk factors of atherosclerosis, which include age, right? Not much we can do about that. Gender. Unfortunately, men are affected more so than women. Or that might be fortunate for you, depending on, where you fall. As well as genetics, right? At least not yet. Men and postmenopausal women are at increased risk for atherosclerosis. And that's because estrogen is protective against atherosclerosis. Thus, menopause is a risk factor as well. The frequency and severity of atherosclerosis typically increases with age. Now, the pathogenesis of atherosclerosis involves lipids, foam cells, and the extracellular matrix. Lipids leak into the tunica intima as a result of endothelial damage, and foam cells are created when oxidized lipids are taken up by macrophages through scavenger receptors. And the extracellular matrix is deposited during inflammation and healing, which also promotes the growth of smooth muscle. Histologically, atherosclerosis consists of a fibromuscular cap covering the necrotic lipid core, which is mainly composed of cholesterol. The morphologic stages, as you know, of atherosclerosis include fatty streaks and plaques. Atherosclerosis is initialized as fatty streaks, which appear to be these flat yellow lesions of the intima consisting of lipid-laden macrophages. The fatty streaks tend to present early in life for the majority of teenagers. The development of atherosclerotic plaque ensues over young adulthood to elder years. Now, over 50% of diseases in Western nations are complications of atherosclerosis. Can you believe that? 50%. Now, some complications of atherosclerosis include peripheral vascular conditions, angina, irritable bowel syndrome, myocardial infarction, atherosclerotic emboli, strokes, aneurysms. The list goes on. You recognize what's going on in this image? You know the organ that it's from? Can you point out the glomeruli? Can you point out the unskinning? Fantastic. Arteriolosclerosis results in small arteriole narrowing. Arteriolosclerosis is characterized and categorized as hyaline and hyperplastic varieties. The protein leakage into the arterial wall, which results in vascular thickening, is the primary cause of hyaline arteriolosclerosis. On microscopy, arteriolosclerosis appears as pink hyaline around the circumference of the vessel. And risk factors for arteriolosclerosis include hypertension and diabetes. Arteriolosclerosis may result in end organ ischemia and reduced vascular diameter, such as the causes for glomerular scarring, like arteriolonephrosclerosis, which advances gradually to chronic renal failure, right? If there's no blood flow to a particular organ because of this issue, then there's lack of nutrients, and then there's lack of oxygen as well, which, as we already talked about in another lecture, becomes atrophic and doesn't work properly, leading to renal failure. Hyperplastic arteriolosclerosis thickens the artery wall by causing smooth muscle hyperplasia in an onion skin pattern. You know what that looks like. Fibrinoid necrosis of the vessel wall may also be seen in hyperplastic arteriolosclerosis. Malignant hypertension, remember that medical emergency? Malignant hypertension may be related to hyperplastic arteriolosclerosis due to rapid decreased vessel diameter. Arteriolosclerosis may result in acute renal failure and has a distinctive flea-bitten appearance. Now let's talk a bit about Monckeberg Medial Calcific Sclerosis. I know the future radiologists are out there just giggling because this is such a classical image from radiology. You can clearly see that Monckeberg Medial Calcific Sclerosis can affect various vessels, right? Monckeberg Medial Calcific Sclerosis results in the calcification of the muscular tunica media portion of medium-sized arteries. Monckeberg Medial Calcific Sclerosis tends to be non-obstructive. Monckeberg Medial Calcific Sclerosis is typically not clinically significant and is usually an unintended discovery in X-ray mammography. Now let's talk a bit about another important condition known as aortic dissection. You're going to see this a lot. Aortic dissection is caused by shearing force, allowing blood leaking through the media of the aortic wall due to an intimal tear. Now this image is showing a CT scan for a retrograde type A aortic dissection in A, and then months later after it was repaired. Aortic dissection occurs in the high stress zone of the proximal portion of the aorta and is accompanied by medial weakening. Risk factors of aortic dissection include hypertension, especially in elderly patients or people, which is characterized by the vasa vasorum hyaline arteriosclerosis. Another key risk factor is genetic connective tissue abnormalities, such as Marfan syndrome or Ehlers-Danlos syndrome, right, which are characterized and categorized by weak connective tissue and cystic medial degeneration, right? Now let's take a pause here because this is very important. I'm sure you've heard of Marfan syndrome and Ehlers-Danlos syndrome, right? Marfan syndrome, as we know, primarily affects the cardiovascular system, right? The heart and the vessels. But how does the patient look? Do you recall? Those long limbs, really tall, right? Whereas Ehlers-Danlos syndrome is characterized as that stretchy skin, right? That extreme joint hypermobility. Now, do you remember the genetic cause for Marfan syndrome? Which gene is affected? FBN1 gene, right? FBN1 gene. And do you recall that gene, protein, being involved with the elastic fibers in the connective tissue specifically? It's all connected. But let's talk about how the media sags as a result of decreased flow in aortic dissection. And that media sag is going to be a problem because the weakness of the connective tissue in the media is a characteristic symptom of Marfan syndrome and Ehlers-Danlos syndrome. Hence the cystic medial necrosis. Now, symptoms of aortic dissection include intense chest pain, right? That should be on the differential for intense chest pain. And chest pain that radiates to the back, right? Complications of aortic dissection include death, right? Secondary to cardiac tamponade, and that's the most common. Could also have rupture with lethal hemorrhage, or obstruction of branching arteries such as the coronary or renal arteries, leading to end organs ischemia. Now here we have a histologic section from a patient that had an aortic dissection that was surgically removed and replaced with a proper functioning surgical replacement. But on this image in particular, you can see the media issue, right? You see that big gaping space where the aneurysm and the dissection was occurring. Here is a chest x-ray showing an aortic dissection. Note the wide aortic knob that is present. And here we can even see on CT with contrast an aneurysmal dilation and dissection of the ascending aorta. This is a type A Stanford type of aortic dissection specifically. Speaking of which, we're seeing a DeBakey type 2 as well as a Stanford type A ascending dissection in this image. Here we have more imaging of an aortic dissection, specifically a CT of the chest with a descending type B Stanford. You can see that in the red circle. Aortic dissection. Here's a cartoon representation of an ascending and descending dissection, hence the DeBakey 1 or Stanford A type. And again, a cartoon representation of a Stanford B or DeBakey 3 type of descending dissection. Note where DeBakey 3A and 3B take place. Now let's talk a bit about aneurysms, okay? You down for that? Let's do it. Thoracic aneurysm is an aneurysm of the thoracic aorta. Thoracic aneurysm risk factors include syphilis and hypertension. Now, regarding microbiology, do you know what organism causes syphilis? Starts with a T, ends with palladium. Treponema palladium, right? You remember that? Treated with penicillin. It's a spirochete. How do pathologists see it? What stain do they use? Warthin-Starry stain, right? You remember that? I'm sure you remember, you know that. What other stain do they use? You know this, you know this. Besides Worth and Starry. Steiner stain, you remember that? I'm sure you remember. And the spirochetes, they can be seen with what type of microscopy? Dark field. It's all tied together. It's all tied together. That's why we need to remember everything as medical professionals. You got this. Now, regarding a thoracic aneurysm, tertiary syphilis is a common cause of thoracic aneurysm. Tertiary syphilis can cause the vasa vasorum endarteritis, leading to thoracic aneurysm due to luminal constriction, reduced blood flow, and vascular wall atrophy. Tertiary syphilis results in the aorta having a quote-unquote tree bark appearance, tree bark look. Complications of thoracic aneurysm includes airway compression, esophagus compression, thrombosis, and embolism. Here we have a stent graft placed in the thoracic aorta to treat a thoracic aortic aneurysm. Lucky them. And here we have a contrast enhanced CT showcasing a large thoracic aneurysm. Can you see that? And again, in the left, we have an arteriogram of an expanding saccular thoracic aneurysm. My mom can see this, so I'm sure that you can. And on the right, we have a post-stent completion arteriogram of a repaired saccular thoracic aneurysm. Make sure you can ID the exact issues here. Don't move forward unless you can. Really take the time to note that bulbous growth in the left image. And where did it go on the right? Wow, treatment worked. Excellent. We love when the treatment works. On this image, we have a thoracic aortic aneurysm with narrow marking the lateral portion, the arrow marking the lateral border of the aorta. You see that? Lots of radiology. And that's because radiology is usually what picks these up in the real life situations. Now, regards to abdominal aortic aneurysm, AAA, that is an aneurysm of the abdominal aorta. An abdominal aortic aneurysm typically develops above the aortic bifurcation but below the renal arteries. A AAA is typically associated with hypertension and atherosclerosis. Risk factors for a AAA include being a man, smoking, increased life experience, i.e. elderly, atherosclerosis, and hypertension. Atherosclerosis causes the vessel wall to atrophy and become weaker by raising the diffusion barrier to the media. An abdominal aortic aneurysm typically presents with a triad of pain that you must know, which are flank pain, a pulsating abdominal mass, and hypotension. I guarantee you will see it. Symptoms of abdominal aortic aneurysm include an abdomen lump that pulses initially and enlarges over time. Complications of a AAA include rupture, especially when the diameter is greater than 5 centimeters. The AAA can also compress nearby structures such as the ureter and cause thrombosis and thromboembolism and embolism. Here's an image of an abdominal aortic aneurysm. You can see where that red arrow is pointing. And with that, you just completed another very important lecture. There's lots of vignettes that play upon these particular findings and instances. Highly likely that you will see it in the near future. So good for you, for reviewing, for practicing medicine, right? Staying smart. I believe in you. You're doing so great. Wow. Very impressed. I'm going to see you next time. Take care.